All right, greeting future doctors and future endocrinologists. So today I'm gonna talk about adrenal hypofunction in addition to incidentallomas and polyglandular autoimmune syndrome and congenital adrenal hyperplasia. This is not a long lecture. Hopefully it will be done in 30 minutes or so. So adrenal insufficiency is the most important insufficiency we can deal with in relation to adrenal glands. And as you know, it's classified into primary or secondary. The classic example of primary adrenal insufficiency is Addison's disease, which is an autoimmune disorder leading to destruction of the adrenal gland. Secondary adrenal insufficiency arises from pituitary or hypothalamic tumors where we lack either CRH or ACTH. And I mentioned here post-bilateral adrenalectomy or infarction. You can call this also primary, so I'm not too fixated on calling it secondary, but it's not well classified. Adrenal infarction does not necessarily lead to complete adrenal insufficiency, and there might be some restoration of function at a later stage. However, post-adrenalectomy, one could say that this follows the same physiology as with primary adrenal insufficiency or Addison disease. Another important situation that we sometimes see, especially in our hospital, when we have metastatic cancer spread to both adrenal glands. I'm not talking about adrenocortical carcinoma, I'm talking about a secondary tumor arising from somewhere else, for example, colon cancer or other places, metastasizing to both adrenal glands. This is a rare scenario, but we have a couple of patients with this condition. And depending on how big that metastasis is, the clinical and biochemical manifestations will be proportional to that. So Addison's disease was described many years ago. This is from a book from 1855. And here you can see the main features of some of the main features of Addison disease, especially the hypopigmentation that is clear here. I'm assuming this is hypopigmentation, and I'm reading it as vitiligo because vitiligo also is an autoimmune disease that can be associated with other autoimmune endocrinopathies like type 1 diabetes or Addison disease or primary autoimmune hypoparathyroidism and so forth. So how do people present with adrenal insufficiency? Acute adrenal insufficiency might be diagnosed following acute stress. Remember, this is an autoimmune process. There's nothing sudden about it. Just like type 1 diabetes, in general, it simmers in the body and the gland is attacked with the antibodies, inflammation, that sort of thing. So the function of the gland declines gradually. But there is usually something that tips the patient over, like an acute illness or acute trauma or surgery or something of that sort that would tip them into frank adrenal insufficiency. Now, another situation is sometimes patients who have already been diagnosed with adrenal insufficiency forget to take their medication or forget to double their dose during an acute illness or get into the hospital for surgery and they don't get hydrocortisone replacement intravenously. Those people might go into trouble. We mentioned bilateral adrenal infarction or hemorrhage, and also what you can see sometimes in Sheehan syndrome due to pituitary infarction. Symptoms and signs, straightforward: dehydration, hypotension, nausea, vomiting, abdominal pain, unexplained hypoglycemia. Again, this is something that we see more commonly in children, not in adults. Unexplained fever, hyperpigmentation or vitiligo, and they have different etiologies. Hyperpigmentation is due to the high ACTH levels. Vitiligo is a separate autoimmune process. And remember that once a patient has one autoimmune endocrinopathy, always stay vigilant and look for other autoimmune endocrinopathies like type 1 diabetes, celiac disease, and the rest of it, or premature ovarian failure, it's very important to keep vigilant for these other associated diseases. So the hyperpigmentation that is seen in primary adrenal insufficiency, or the presentation with hyperpigmentation in primary adrenal insufficiency is typically in younger patients. So this example that we're seeing here is of an older person, which is a bit uncommon but still happens. You can see the bronzing of the skin of the face and also the palm before treatment with the top right picture compared to a normal hand, and in the bottom right picture we see after treatment with steroids, ACTH level comes down and hyperpigmentation resolves. Of course, it's very important also to look inside the mouth cavity for buccal hyperpigmentation, because the skin is sometimes difficult to determine. So always look into the mouth and look at the gums, because they can also be hyperpigmented. How do you investigate primary adrenal insufficiency? Again, history, physical, and you feel that there's something suggestive of adrenal insufficiency, like hypotension, electrolyte imbalance. So you do an ACTH level, you do a cortisol level. You would expect the ACTH level to be high and the cortisol level to be low. Sometimes that is sufficient for establishing a diagnosis if the picture was clear cut. However, at times we like to do an ACTH stimulation test, and what you would find is flat response, meaning no rise in cortisol level after the ACTH injection. Now, you would want to look into the pituitary if the clinical picture was going with secondary adrenal insufficiency. In that case, the ACTH level will not be elevated. It might be inappropriately normal or on the low side. So in this situation, you might think of secondary adrenal insufficiency, so pituitary imaging is indicated. Adrenal imaging, I would only do that if I suspect metastasis to the adrenal glands as a cause for this adrenal insufficiency. So the history is suggestive, basically somebody with widespread metastatic cancer coming with features suggestive of adrenal insufficiency, electrolyte imbalance, hypotension not explained by sepsis. Then I might consider doing abdominal imaging to look at the adrenals. How do you treat it? Well, you have to provide the patient or replace the patient with both glucocorticoids and mineralocorticoids. We try to mimic the circadian rhythm by giving a higher hydrocortisone dose in the morning and half of that dose during the late afternoon or early maghrib time, yani sunset, and nothing at night. Mineralocorticoid like fludrocortisone can be taken just once a day, regardless of the time. Remember sick day management. They have to double the dose if they got sick for several days. If they were unable to take their medications orally, they have to come to the emergency room to get it parenterally. This is very important, and the medical alert bracelet should be worn all the time. Moving on to the next topic, adrenal incidentallomas. So any adrenal mass more than 1 centimeter, which is discovered incidentally by a radiological examination. We get a lot of referrals from many different specialties in this hospital for such condition. Typically, the patient does not manifest symptoms suggestive of functioning like hyper or excess secretion of any of the adrenal hormones. However, it falls on the shoulders of the endocrinologist to ascertain the lack of such symptoms and signs. So the main approach to such patients is through two big questions. The first one is this adrenal mass a cancer? The second question is it hormonally active? How common are adrenal incidentallomas? Well, it depends on the population where the study was done on. If you go to peripheral hospitals which handle primary or secondary cases, the incidence of incidentallomas might be on the lower side. If you come to a tertiary reference hospital like ours, Alfaisal Hospital, the incidence might be bigger because we deal with a lot of patients with cancer who can metastasize to the adrenals and so forth. Also, incidentallomas increase with age, so again, it depends on the age of the population that you are looking into. So incidence is variable, anywhere between 0.4 to 10% of CT scans of the abdomen. Now, people can also present with bilateral masses, and you can see that in congenital adrenal hyperplasia, metastasis, tuberculosis, hemorrhage, so keep that in mind. The majority of adrenal incidentallomas are benign. This is a very important piece of information to deliver to your patient right away. Here are some examples of adrenal masses. The top left image shows a large adrenal tumor, 8 centimeters, clinically silent pheochromocytoma. This was a real case. On the right top side, you will have a 1.5 centimeter adrenal adenoma, Hounsfield units 4, which is in keeping with the benign adenoma. And on the bottom, you have an angry looking adrenal mass with calcification. Look at the arrow. This is very worrisome for adrenocortical carcinoma, which is the case. So predictors of cancer versus benign tumors. First, the size. Masses larger than 4 centimeters have higher risk of being cancer, and the cancer we're talking about is adrenocortical carcinoma. Radiograph attenuation on non-contrast CT. This is a unit that we utilize, or the radiologists utilize, to give us the attenuation or density, pixel density on that image, on that area of the adrenal tumor. If the Hounsfield units were less than 10, then this is in keeping with an adrenal adenoma, which means a benign lesion. If you have higher than 10 Hounsfield units, the radiologist will typically administer the contrast to determine the washout percentage of that adrenal gland. The washout means how quickly the dye enters and leaves the adenoma, measured in minutes and percentage. So they call it washout. So the more rapidly the tumor washes out the contrast, the more likely it is benign. And the longer the dye stays inside the adenoma, then the more likely it is malignant. That is suggestive of what we call myelolipoma. So despite its big size, it's 100% benign and does not need to be taken out. Although here we can see the pathology sample below, the tumor was removed and the diagnosis was confirmed. So myelolipomas are the only exception to the 4 centimeter rule, because if it's clearly a myelolipoma, then you don't have to worry about the tumor in terms of cancer versus benign lesion, because they're always benign. However, you might still want to rule out functionality of that tumor. Now, we talked about workup for hormonal overactivity in today's lecture, so I'm not gonna go over it again. Treatment of adrenal incidentallomas. These are some of the main rules that we follow. If the tumor was hormonally active, the gland needs to come out. So if it was a Cushing, if it was pheo, or if it was primary hyperaldosterone or Conn syndrome, you need to resect the tumor. If the tumor was more than 4 centimeters, regardless of functionality or not, it has to come out, and we mentioned the only exception is myelolipomas. If you have high suspicion for cancer, meaning even if it's less than 4 centimeters, but the Hounsfield units are high, more than 10, the washout was not rapid, for example, or there are some suspicious features like calcification in the adenoma, then you would need to do adrenalectomy as a precaution. We only perform biopsies to determine if the patient has another primary tumor metastatic to the adrenal gland. We do not do adrenal biopsies to distinguish between adrenal adenoma versus adrenal carcinoma, because the biopsy cannot tell the difference between the two. The biopsy can only tell us if the cells are originating from the adrenal gland or if they are originating from another tissue like colon cancer or breast cancer or any other type of cancer. So that's why we only perform biopsies when we have history of primary cancer other than the adrenal, and we want to know if this is metastatic primary cancer to the adrenal, or it's something from the adrenal itself. Remember, before sticking a needle into anyone's adrenal mass, to rule out pheochromocytoma biochemically, and then you can do a biopsy if the patient did not have pheochromocytoma. The fifth rule is that if a patient has a rapidly growing adrenal mass, even if it's less than 4 centimeters, for example, it was 1 centimeter last year, and 6 months later it's 1.5, and 6 months later it's 3.2, then you have to remove it. It's rapidly growing with worrisome behavior. If the tumor was not hormonally active, less than 4 centimeters in size, no rapid growth, you can just follow up that patient annually with imaging, repeated imaging, and repeated biochemical testing to rule out functionality. Because if a tumor was not functional today, it doesn't mean that it will not become functional in a year or two. So we mentioned the role for adrenal biopsy. It's only done to differentiate. It's only done to differentiate between adrenal origin of tumors or cancers versus metastatic cancers. This will lead us into adrenocortical carcinoma, which is luckily a rare disease because it's a very, very bad disease with poor prognosis. In adults, it presents in the 4th and 5th decade in their life, but I would tell you that almost all my patients are younger than that for whatever reason. So it does happen in younger population, of course. More common in men, aggressive with low survival. 60% are hormonally active and present usually with Cushing's syndrome in men, and Cushing's syndrome and hyperandrogenemia in women. Treatment is surgical. We have to try to resect the full tumor. We usually do not do laparoscopic adrenalectomy on these people. We prefer to do open surgery in order not to leave any tumor behind, and to do good resection of the margins and neighboring areas. Sometimes the surgeon would need to do nephrectomy if the tumor was invading the kidney. So it is somewhat a radical surgery. If the surgery succeeded with complete resection of the tumor, there is still a very big chance of recurrence at a later stage, whether recurrence locally or metastasis to lymph nodes and so forth. So we typically treat patients with mitotane as an adjuvant form of chemotherapy, which is taken orally. And if the patient presents with distant metastasis, we can offer them chemotherapy. And sometimes we use local treatments like radiofrequency ablation to ablate certain metastatic lesions in the liver. And if the patient has recurrence of Cushing's syndrome, we should treat those people medically in addition to mitotane. Congenital adrenal hyperplasia, we discussed this a bit this morning. It's an inborn error of metabolism. The most common form is 21-hydroxylase deficiency, where there's defect in conversion of 17-hydroxyprogesterone to 11-deoxycortisol. And you see, and 21-hydroxylase deficiency accounts for at least 95% of cases of congenital adrenal hyperplasia. It's autosomal recessive. This is the pathway for steroidogenesis in the adrenal gland, and we said earlier that because of lack of cortisol feedback to the pituitary gland, the pituitary continues to produce more and more ACTH, which will eventually lead to satisfactory level of cortisol if there was some activity in the enzyme, of course, not if it was completely deficient. So when the pituitary produces too much ACTH, as a byproduct or the expense of that is too much androgens. So the patient will present with hirsutism, acne, irregular period, and so forth. It's classified into two types, the classical and the non-classical 21-hydroxylase deficiency. The classical usually presents in very young age, especially if it was salt losing. Salt losing meaning you don't have also aldosterone production. So in girls, they present with ambiguous genitalia, rarely adrenal crisis if genitalia are not too deformed. In boys, typically present with adrenal crisis, hyperkalemia, hyponatremia, and failure to thrive. The non-salt losing, which is a bit less severe, people or the fetus is born with ambiguous genitalia in girls, of course, not in boys. And you can see the clitoromegaly in an infant with 21-hydroxylase deficiency to the right side. The non-classic 21-hydroxylase deficiency is what we as adult endocrinologists see more of. They're called late onset, and typically those are young women who present with hirsutism and amenorrhea. The clinical picture is very similar to polycystic ovary syndrome. However, they have elevated levels of 17-hydroxyprogesterone, which gives us the diagnosis. Also, they have hyperandrogenemia, meaning maybe elevated DHEAS level, elevated testosterone level, or free testosterone. So these are some features of this condition in adults. How do you treat it? The treatment mainly consists of decreasing androgens. So how can you decrease androgens? You try to decrease ACTH, because ACTH is what driving the hyperandrogenemia. How do you suppress ACTH? By giving steroids. So the best way to give steroids is to use dexamethasone, 0.25 to 0.5 milligrams at bedtime. And we sometimes supplement those patients with hydrocortisone to meet their daily requirement. Some patients do not need it, so it depends on your patient. If the patient has salt-losing type, they also need to be treated with fludrocortisone. Our last topic is about autoimmune polyglandular syndrome. Briefly, these are autoimmune disorders affecting several glands plus non-glandular tissue. They're classified mainly into two categories. There are more, of course, but this is just to simplify things. So autoimmune polyglandular syndrome type 1 is autosomal recessive, and type 2 is polygenic. You can see the associated genes, AIRE gene mutation in APS1, onset in infancy usually for autoimmune polyglandular syndrome type 1, and the clinical features include mucocutaneous candidiasis, hypoparathyroidism. Those are the big ones if you want to remember two things: mucocutaneous candidiasis and hypoparathyroidism. Of course, Addison's disease is part of it, diabetes type 1 is part of it, and other things. Now, APS2 is more common. The presentation is usually at an older age, 20 to 60 years. They do not have autoimmune hypoparathyroidism. They do not have mucocutaneous candidiasis. Again, those are the two main distinctive features, at least clinically, in addition to the age of onset, of course. Now, people with APS1 can present with so many other autoimmune disorders like gonadal failure, alopecia, vitiligo, intestinal malabsorption, and so forth. They usually present at a younger age. And here you can see features of mucocutaneous candidiasis, the tongue and the toenails. APS2 has a later onset in general. No specific gene mutation because it's polygenic, and organ-specific antibodies are often present even in the absence of overt clinical disease. This is a bit important. What does this statement mean? Okay, so if you have somebody with late onset, for example, or adult life onset of polyglandular autoimmune syndrome 2, suppose this patient presents with type 1 diabetes and later adrenal insufficiency. So now you're thinking, is this are these two conditions part of autoimmune polyglandular syndrome or not? And you want to anticipate, for example, whether this patient has the propensity to develop more autoimmune disorders. So we said that here, for example, the example I'm gonna go over again. So somebody who has, let's say, Hashimoto thyroiditis, okay, which is an autoimmune, and type 1 diabetes. Okay, so you start thinking, does this patient have other autoimmune disorders? So one of the markers or antibodies to predict the occurrence of adrenal insufficiency is to order the anti-adrenal antibodies. Now, having positive antibodies doesn't necessarily mean that the patient will develop adrenal insufficiency in their life. So it's not very helpful to order those antibodies preemptively, because the expression of the disease is not always linked to the presence of those antibodies. So that's what we mean by that statement.